I'm Dr. Craig Escudé, the host of IDD Health Matters, a podcast where we talk about health, wellness, and health equity for people with intellectual and developmental disabilities. Hope you enjoy it. Welcome to this episode of IDD Health Matters. We have a very special guest today, Dr. Maggie Nygren. She is the Executive Director of AAIDD. Welcome, Maggie.
Thank you.
So tell us what AAIDD stands for, first of all, and then tell us about the organization.
AAIDD stands for the American Association on Intellectual and Developmental Disabilities. It's a mouthful. Even saying AAIDD is a mouthful.
Yeah.
It was founded in 1876, and I emphasize the 18 because I was not there. It was founded in 1876, and it was founded actually by a group of superintendents of institutions for people with developmental disabilities.
At that time, there were pretty much only institutions, right?
Yeah. And over the years, the association has gone through 5 names. We adopted the current name a number of years ago, but what hasn't changed, the organization has always been about understanding the causes of intellectual and developmental disabilities and understanding the evidence about the best interventions, what's most effective to support people have the fullest life.
So there has been a lot of evolution in that area over the years, certainly. And I know that AAIDD does focus quite a bit on research in the field.
So our mission statement has to do with research, practice, and public policy. So the 3-legged stool. The research is the evidence that informs good public policy, and the combination of research and public policy influence best practice. So all 3 are involved with AAIDD. Our activities include education, like conferences, webinars, and so on.
Speaking of conferences, we happen to be coming to you from the national conference this year in Pittsburgh, right?
That's right, yeah. I'm glad to take a break and do this with you.
I appreciate you taking the time to do it because I know you're quite busy at these conferences.
Busy time. We publish 3 peer-reviewed scholarly journals. So we disseminate, the research on what works, what doesn't work. And then we also, I mentioned the education, we also publish a full catalog of books, curricula, and assessment instruments to help people, do their best practice to help people with intellectual and developmental disabilities, achieve their own goals and have the best quality of life.
And you do have great publications, and if you're looking for books in this field, AAIDD and the website is a great place to go and find a lot of really well-written and very informative books about this field. You also mentioned assessment tools. Mm-hmm. Let's talk about that for a second.
Absolutely. So we're probably pretty well known for our supports intensity scale, which we call the SIS. And there's an adult version called the SIS-A, and there's a children's version called the SIS-C. And what's interesting about these tools is they approach understanding a person's support needs as what a person needs to achieve their goals. And that's different from a deficit model when you're assessing what someone can't do. You're assessing what someone would need to be able to do. So it's a difference in approach. One is for children, one is for adults. They focus in on the kinds of activities that children or adults would be engaged in. Typical activities in school for children or in the community, or for adults even in the workplace. And dating, and the kinds of activities that we would expect of all people if they're a child or an adult. And it goes through very methodically and looks at what kind of supports a person would need to be successful. And that information then can inform a support plan. And the goal then is to get people to be optimally integrated in their community, fulfilling the typical roles that they would fill as an adult, or if they're a child, fulfilling as a child.
And that tool is pretty widely used, isn't it?
It's used around the world. It's been translated into many languages. It's on statewide use in most states and most Canadian provinces, actually. We have another tool that we're a little less known for, but it's a very good tool. It's called the Diagnostic Adaptive Behavior Scale, or DABS. And I don't know how much detail I should get into, but when you're diagnosing intellectual disability, there are 3 criteria. One has to do with age of onset. One has to do with intellectual functioning. That's typically measured by an IQ test. And then the third criteria has to do with adaptive behavior. And there are a number of adaptive behavior scales on the market, but ours is very, very precise, and particularly at the upper end of the spectrum. So there are people who are pretty close to the upper range of the condition, and if you don't have a tool with great specificity, there's a real risk that someone will be inaccurately measured. And that inaccurate measurement will result in them not getting the diagnosis and then not getting the services they need. So having a really specific tool, that great deal of specificity at the upper range is really important for some people.
That makes a lot of sense, actually. And related to that, I've heard recently some talk about a state deciding that you couldn't use IQ scores anymore for diagnosing a person with a disability. Are you familiar with that?
I am familiar.
And I'm curious about your thoughts on that. I have my own I'll share.
Well, I'm going to take the big view here. The big view is that when you write legislation, you want to be precise. You want to have no room for error, no misunderstanding. And for a long time, when states were writing their regulations and laws about who would be eligible for some benefit program or some system, they would say, well, there's a bright line. If you're under this line, you're in. If you're over this line, you're out. And they would use an IQ score as that bright line. Mm-hmm. And it meets the needs of the legislature and the policymakers because it's so clear. You can't be confused about that. But one thing we've learned over the years with intellectual disability and assessment instruments, there's a bit of a standard error of measurement, a bit of a range. So even though someone might have a score of, let's say, 69 on an IQ test or 70 on an IQ test, that's the score they achieved, but statistically it could be a point or two above or a point or two below. That's really hard for legislators to write into law.
Yeah,
they want
understood.
A bright line. And so when faced with the idea that the score is really a scientific estimate, and that even though they got a particular score, it really could be 2 points over or 2 points under, that's so difficult for them. So they just, for some states, they said, well, you know, we don't want to write that into law. We're going to trust in clinicians and their clinical judgment. They can follow that, and they're going to give us a diagnosis one way or the other. And it's their license on the line. They're saying this person has intellectual disability, and that will be the thing that is, for us, the dividing line.
That makes sense. And I think, like so many diagnoses that we make as clinicians, there always is some gray area, and you're not always 100% sure it's one thing or the other, and you have to use a lot of different factors or a lot of different maybe tests or part of the history and part of the physical and part of the testing to come up with the best diagnosis. And there is some gray area in that sometimes. So I can see that. I can see that point about it being a little challenging to write into legislatures.
Yeah, and when you start adding things like, you know, it's got to be a culturally appropriate test, and this is difficult, I think, for legislatures to write a clean listing of who's in and who's out. And that's their job. They want to identify who gets the benefits and where the cutoff is. And when you're doing the diagnosis, when you're doing those other things, that's a different job. That's a job about accuracy in diagnosis. It's not a job about benefit determinations.
Yeah.
And so that the legislators are concerned with benefit determinations.
Well,
you're concerned with accuracy and diagnosis. So
I really appreciate you sharing your perspective on that. I've learned a lot in that.
oh my goodness.
So let's talk about Dr. Maggie. So how did you come into this role, into this field?
Well, I started out thinking I wanted to work with children. And then I discovered that often what that really means is you're working with their parents. So I didn't really, I didn't want to do family work. I wanted to work with the audience that, the population I wanted to work with. And so I thought, well, you know what, maybe I'll work with elders because they don't have parents. Be fine. But it turns out they have adult children.
Yeah.
And I got a job at a senior agency directing a program, a family support program for older families who had an adult with intellectual disability. And so that's how I sort of came into the IDD realm. And I said, well, this is where I want to be. And then I moved on into other jobs that were just more clearly focused in intellectual and developmental disabilities.
So, I've found in my experience and also in people that I've known that this field, you kind of either know it's for you really quickly or it's not for you really quickly. And sometimes you kind of fall into the field and you're like, this is where I need to be. This is where I need to spend the rest of my career. Did you have a similar experience?
Well, I did. It was in that job, that family support job, where I said, yeah, this is the population where I'm meant to be. This is where I need to be working.
Yeah.
So I did many, many different kinds of jobs. I went back to school. I did all different kinds of things, but I've stayed in intellectual and developmental disabilities, and it was the right decision for me. It's a great field to be a part of. You see the impact of your work. You see how people's lives are improved. You see that you're bringing something to the table that's actually meaningful. Yeah. You're not a cog.
Yeah, there's a lot of rewards that come to working in this field, from working in this field. So back to AAIDD, what are some of the hot topics in the field right now? Would you say, or hot items that AAIDD is working towards?
Well, with the caveat that every topic affects people.
Sure.
If it affects people, it affects people with intellectual and developmental disabilities. There are some pressing issues on the field that I'm happy to talk about that we are a part of. And then there are a couple of topics that are probably of most concern to a small sliver of the field, but that are big for us. So we work a lot in death penalty cases, explaining to courts about intellectual disability, what it is. Oftentimes people with intellectual disability who are convicted of a crime, there's some question about whether or not they have intellectual disability, and if they do, they're covered by a Supreme Court decision that says execution is off the table. And so on appeal in those cases, and this is not a question about whether or not someone's guilty, that's not what we're involved in, but we're involved in explaining to the court on appeal what are the criteria for intellectual disability so that their case can be properly adjudicated. Yeah. It's not a question of guilt, it's whether or not the death penalty is on the table.
Important work there.
Yeah. A big pressing issue in our field right now is workforce, the direct support workforce.
If you work in this field at all, you've heard that once or twice already. It's certainly been challenging. Mm-hmm.
So, we really want to improve the working conditions for direct support workforce, and we want to increase the number of people that find that to be an attractive career. Another area that we really work on is really just about emerging knowledge about what works and how best to support people. And that's in every life domain.
Yeah.
I know it's from transit. If you're a child transitioning into adult services, what works best? In community inclusion, what works best? Employment, what works best? Dating, taking care of yourself in terms of advocacy and self-determination. So there's no topic really that's off limits.
When you mentioned transitioning from a child to an adult, from my health perspective, that's a very challenging time when you're looking for health care. Typically, children with intellectual and developmental disabilities, they typically have a pediatrician, and pediatricians do have training in this field. But then they go into the adult realm, and many clinicians still, unfortunately, do not have training related specifically to providing health care for people with intellectual and developmental disabilities, and they often have a lot of trouble finding a clinician at that point. So I can certainly relate to that transition component from the medical side of things.
Yeah, so from both the medical and from a social services perspective, we do have a dividing line. The pots of money that pay for care and that pay for social services are different for children and for adults, and the way they're delivered differ for children and adults. And we talked earlier about eligibility for services. For most people with intellectual disability, the pathway to eligibility for services is to be on Medicaid. Yeah. So that means that they meet a poverty threshold, and it means that while Medicaid will pay for services, there are a shrinking number of clinicians that are able to take large numbers of Medicaid-funded patients into their practice. As well as the issue you point out, people's comfort level, do they feel that they've been adequately trained?
Right.
And then you see people who are adults, 20, 30 years old, still seeing pediatricians because they can't find a GP or an internist who could see them because of the Medicaid or their lack of comfort. They don't feel they've been adequately trained.
Yep. And that speaks to my biggest passion in this field is to work to improve education and training for healthcare providers of all types, really, to be able to meet the needs of people with intellectual and developmental disabilities. Mm-hmm. So, Maggie, one of the things that I like to challenge guests with something I call 3 and 3. Okay. So it's 3 things in 3 minutes that you think can improve supports and services or health and wellness or just general well-being for people with intellectual and developmental disabilities. So three tips, tricks, words of wisdom, advice, pieces of advice that you would like our listeners to know.
So these are like pie in the sky?
Yeah, whatever you want them to be.
Or are they more practical things?
I'll leave that to you to decide.
Well, of course, if there was more money, that way.
Okay, maybe not that high in the sky, because that one's tough. You know that.
Yeah. I think the first thing, it really just comes down to values. I think that if we had a sort of a universal set of shared values that include the idea that people with IDD are people, and that they in fact do have the same civil and human rights as people who are typically developing. And I think that's the biggest hurdle. I think there are a lot of sort of unconscious biases, preconceived notions, or expectations that prevent people from really embracing those values. And I think embracing the values would go a long way because it would change really how you approach any number of situations. And I don't mean to be unfair. We all have worked out shortcuts in our minds. We know how we're going to deal with the DMV. Right. Or, and maybe if we had approached it differently, we would have been more successful. But I think that's a good way of looking at it. I mean, rather than the preconceived notions, maybe sit down and really think about that. And if I truly, believe what I say I believe, how would I approach this? And then actually do it. I think that it's one thing, really. It's getting us all on the same page, and that page is about humanity, and recognizing that people do have, it's weird to say, but people are people and they have rights.
Rights and value.
They have value.
Yeah.
Yeah. And sort of related to that, we have to all hold each other accountable. And that also means that people with disabilities, if they promise to do something, they need to do it. They have to be accountable to us in society, everyone in society, as we have to be accountable to everyone in society. And that includes people with disabilities.
I like that. So I think that's two.
That's two.
Do you have one more?
Oh, we should all have a lot more chocolate, I think.
You know what? I second, third, and fourth that one.
I think it's about respect and accountability,
Yeah. Well, Dr. Maggie, thank you so much for taking the time out of this busy conference schedule to talk with me today. But more importantly, thank you for the amazing work that you do. Keep leading us on.
Well, thank you so much. It's really been a pleasure.